Good afternoon, everybody, and thank you so much for joining today's webinar. We're very pleased that everyone can join us today, but we'll just wait for everyone to come online. Today's webinar covers off a really important topic, system recovery, and we'll get started in just a few moments. Everyone will be placed on mute as they join. But we do encourage you to use the Q&A function for questions, please. The webinar is being recorded and will be made available to those who have signed up. Do please use the Q&A function to ask your questions. And I think we're just about on time, so I'm going to hand over to our chair for today's session, Dr. Graham Wilkes. Thank you.
Thank you very much, Ali. Good afternoon and welcome to everyone joining this Connect Change webinar. My name is Dr. Graham Wilkes. I'm your chair for today. I'm the Chief Medical Officer for Connect Health. I'm a sports and exercise medicine consultant and an experienced past GP, no longer practicing in primary care. And I think I am the only practicing clinician on the panel today, so if need be, I can give a clinical input. This is the 13th of a series of Connect Health Change webinars, which are set up to support system leaders and clinicians across the NHS to provide practical solutions, discussions on the challenging issues we're all grappling with. And clearly today's topic is undoubtedly the largest topic we're grappling with at the moment. Just for information, because these are on the Connect Health Change webpage, our previous seminars, which have been very well attended and with excellent feedback, have been on rheumatology, chronic pain. We've covered long COVID, service redesign now today, first contact practitioners, education, quality improvement, and a session on IAPT and mental health, which I also chaired. So today we've got an impressive lineup of speakers from a wide range of backgrounds who I think are very well qualified to talk around system recovery. So just in terms of how this works, the webinar works, if you haven't been on one before, each speaker has been asked to present for 7 minutes of their 10, and that will leave a few minutes for some immediate questions, but most questions that you pose we'll put at the end in the format of a panel where everyone can contribute. So basically, in terms of the subject today, I just wanted to give a few thoughts, I guess, as an experienced clinician of 37 years. And I think one of the issues, we've got a real expert panel, but in reality, none of us are truly expert at how to come out from a pandemic. And clearly that's the problem. We're using our past experiences to deal with a new situation of uncertainty. And I just wanted to sort of draw an analogy as a clinician over many years. As a doctor, I've got pretty used to dealing with uncertainty in how I manage patients. And I think two areas where I think it's really important for how we come out of COVID is, I think when things aren't good, when there's bad news there, I was taught early on in my career how to break bad news to people. And the key principles are, first of all, you have to tell the truth and you just have to get it out there. And most people appreciate hearing the truth and so they can deal with it. But one absolute key feature of this is, as well as being empathetic, is always to give people hope. And that's something throughout my career that I've found, whether breaking news about death or cancer or other difficult areas, always give people hope, and I don't think we've always done that so well during the pandemic. Some have and some haven't. And the other really important thing with the public is to tell the truth and don't fudge with the reality of the situation. The public can deal with bad news, and they get on board and they become partners in that. So I think it's really important that the expectations are realistic as we come out of COVID, because if anyone sets unrealistic expectations, then that will not help us all work together to make the best of where we're at. And I know all the speakers today will have all those principles at heart. So just to position where we are coming out of COVID, hopefully we are coming out of COVID despite the Delta variant, that we know that statistics suggest there's approximately 5.1 million people waiting for treatment, and that's clearly an issue that we'll talk about today. And of course, people who've been waiting that long do have an expectation to be seen as soon as possible. But again, we need to be realistic about that. And in addition, we really haven't got an idea what is coming down the pipeline. We know there'll be a lot of people currently still in primary care who will want to be or need to be referred through the pathway, through community and into hospital care. And so this is not going to sort itself out in a short period of time. And again, that will be a topic of discussion, I'm sure, today. So in terms of today's webinar, we're going to cover from various angles. Our speakers come from a range of backgrounds, not just the NHS, and including the patient view. We'll be looking at the impact of waiting lists on every part of the system, innovations and ways to try and inspire and educate as we move forward, and some examples from our speakers on initiatives and ways that they're already trying to solve the backlog challenge. We need to think about how we change, and a big topic is what have we learned from COVID, and what are we going to continue and what are we not going to continue, and also move to digital change is quite a key topic, which I'm sure we'll touch on. So it's a big topic and nobody knows the answers, but we're going to have a go today to see if we can make some sense out of it, and I'd like you to play your part in asking questions to guide us along the way. So it gives me great pleasure to introduce our first speaker, who is Ken Bremner. Ken's Chief Executive of South Tyneside and Sunderland NHS Foundation Trust. He's been in and around Sunderland for many years and is very experienced from a secondary care point of view. And he's going to tell us how Sunderland and South Tyneside are addressing the challenge. So over to you, Ken. Thank you.
Thank you very much, Graham, for that introduction. I'm going to try and hold true to your two key comments around truth and hope. So here we go. My session today, good afternoon, I'm Ken Bremner, Chief Exec at Sunderland and South Tyneside and Sunderland FT. As you heard, my brief today is to cover something around system recovery and some of the issues that we're doing to support staff through that recovery. And I'm going to turn it around and deal with the system recovery bit first, if I may. So if I can move on to slide 1. So I thought I'd just start with a bit of perspective about my own organisation, where we're sitting on a couple of key metrics compared to the national position. You'll see on the graphs this reflects A&E attendances and A&E percentage seen within 4 hours. The green data, green lines dotted and fixed, are national data, and the blue lines are my own organisation. So you can see in the top left the impact on attendances at A&E both nationally and locally over the last 12 months or so. This runs to March this year, measured on the right hand column by nationally, and the left hand column my own organisation. Do notice the end of year position in March, where both those fixed lines have now moved back up above the similar position we had in 1920, and that trend, I'm afraid to say, has continued into 21-22 as well. On the performance angle, yes, you can see the decline in performance in the A&E position against the 4-hour target. Interestingly, above my own organisation, actually, our performance has improved when I compare it to 1920, and that might be something about some of the patients that previously came into our A department aren't and haven't been coming. We always felt an element of those should probably be treated elsewhere in our system rather than coming into our ED departments. Next slide, please. This is cancer 62-day performance and RTT, again, the effects of the pandemic. You can see the national target on cancer on the top left. There's a 62-day performance in particular. Again, the national position has been broadly stable and consistent with the same period in 1920. My own organisation's performance has been a little more volatile, actually, but you might expect that at an organisational level. By and large, we have improved our performance in 2021 on 62-day performance compared to previous years, but still some gaps to catch up on nationally to consistently deliver that. And an RTT, you see perhaps some of the most marked changes, particularly the decision the NHS made, as you know, to postpone, defer, cancel all elective activity from essentially April last year. And you can see the trends in both my own organisation and the national position. And actually our position and performance in RTT has got worse as an organisation this last year, even though it recovered in the sort of September to October, November period. It's still not back to where it was. And of course, all that as a consequence is giving us some of the numbers that Graham identified at the start. Next slide, please. So if I can move now on to what impact has that had on us as a region? And by a region, I'm now talking about the North East and North Cumbria, which will be a formal ICS on the 1st of April next year, and is at the moment the single biggest ICS in the country, with quite a wide geographical spread up to the borders across the west and east coast and down to North Yorkshire. So where we are coming out of last financial year, we've got a waiting list number now that's just under 263,000, with a wide range of volume issues facing our individual trusts. And they range from one trust having a waiting list of just over 1,100, right up to one trust having 77,000 on their waiting list. So a marked variation in the size and range and scope of numbers. A&E performance back up to just over 90%, which is okay, but that's coming under increasing pressure in 21-22. Over 52-week waits, the longest waiters, have risen considerably and now stand at just over 18,270, again as at the end of March. Cancer 62-day performance running about 76, 77, 78%, so nowhere near where it needs to be. And our diagnostic performance as a system is way off where we should be in terms of that 6-week performance metric. And of course, as Graham said, I'm giving necessarily today perhaps a more secondary care focused perspective on some of these issues, but I would want to also acknowledge the impact clearly on primary care and mental health colleagues as well. And they are seeing many of the same trends that we are in secondary care, about the increasing tsunami now of unmet demand that's going to be hitting us in coming weeks and months. And of course, we all know there's an unknown to this that we can't quantify right now. And if anything, that's the bit that probably worries me most in all this. What I can see and deal with is there, it's visible, but what I don't know is much more difficult to quantify and predict what will be coming through primary care into hospital in due course. Next slide, please. So our approach in the North East and North Cumbria, the ICS, is to try and look at system recovery on a regional basis, in the whole, in the round, if you want. And what we've accepted is that because we've got so much variation in our hospital sites, we need to collaborate together effectively to try and tackle some of these problems. Now, the geography doesn't always help. When you've got Workington on one side and Teesside and Sunderland and places on the other, 70, 80, 90, 100 miles apart. But we nonetheless felt this needed to be a collective effort. And as you know, the NHS is approaching this recovery or system recovery now, looking for a number of elective accelerator sites. And I'm pleased to say that we will be one of those in the North East and North Cumbria, with a bit of investment, probably somewhere between 10, 20 million capital to help us make that a reality. So collaboration is the watchword, and that's collaboration at all levels. And I would say that that collaboration is important because what we want to try and do is get all units in the North East down to a particular waiting time as quickly as we can. That might be 40 weeks. for example, and try and change, certainly in the short term, the shape of that waiting list, particularly focusing on the over 52-week waiters and those P2, those priority 2 cases that have been waiting over a month for treatment. So change the shape is going to be the sort of initial push from us. We'll do that by extending some of the innovations we've introduced during the pandemic, extending our weekend and evening working, looking at making better use of our operating capacity and expanding rapidly where we can our diagnostics. Diagnostics is a key issue in helping us recover. Probably haven't got sufficient of it within the NHS at the moment. That will probably necessitate some use or increasing use of the independent sector as well, at the same time as more one-stop clinics. And I mentioned it previously, we had about just over 18,200 long waiters now on our waiting list. Almost half of those appear in 2 areas, ophthalmology and trauma and orthopaedics. Trauma and orthopaedics affects virtually every acute hospital in the Northeast. Ophthalmology only affects a certain number, 3, possibly 4 organisations. So the solutions to tackling problems in ophthalmology and trauma and orthopaedics will be slightly different, but we will have a focus almost, not exclusively, but we'll have certainly a focus or a priority given to those 2 particular areas. We're also conscious we want to try and get to a position where we've got a sustainable stroke manageable waiting list, because obviously, as we all know, winter's not too far away either. Next slide, please. So on to the recovery of staff. You might say the most important thing that we've got to get right as an organisation, more than the physical capacity, more than X-ray machines and all that stuff, we've got to make sure our staff are fit and back on the road to recovery themselves. So there's 6 broad areas I wanted to briefly cover in the short space I've got left, and give you some examples of some of the things we've been doing. Firstly, we had to deal with a number of staff who have obviously been shielding for quite a long period of time. At one stage, I think we had about 400, just over 400 of our workforce away shielding. They're all drifting back now, or have been since the beginning of April. So, of course, we've been doing all the dedicated risk assessments and taking appropriate occupational health advice. We've also been looking at trying to redeploy staff into lower risk areas and adapting their ways of working. So looking at things like start and finish times to help people get back into routine. Health and safety is never far from our mind, as you can probably imagine, and that can cover anything from ensuring staff have got absolutely up-to-date and accurate advice on infection prevention and control and PPE, through how we are supporting our staff to work at home with the IT equipment and systems, again making it and facilitating it and making it safe for staff to work from home, making sure we're monitoring annual leave through electronic staff records regularly to make sure that staff actually are taking breaks and we're not leaving everything to become a big problem in quarter 3 and quarter 4, which is traditionally winter anyway for us. And under well-being, I think we have done quite a bit as an organisation, not just appointing people to be guardians and responsible. We've actually decided to invest in our own dedicated psychological support service now for staff. So we will employ our own team, supported by our IAPT team that works in the community already, particularly from South Tyneside. But that will be a great facility that's coming on or came on stream on the 1st of June and will build up this year. We've already got things in place like dedicated fast track physio services for MSK patients and the like. But also we've appointed an occupational health, mental health advisor to also support staff as well. And where we've got staff on long COVID or who have got long COVID symptoms, we've also tried to do a much more bespoke road to recovery programme for them as well. EDI continues to be a key theme, not just making sure all the risk assessments are done for colleagues, some of whom are clearly vulnerable colleagues, but also making sure we've got greater input from our senior team into some of the networks that we've set up. We've got 3 networks in the organisation, one for BAME, one for LGBT+, and one for positive health. And that's listening and hearing some of the feedback from our staff about the difficulties that they face, exacerbated during COVID, and how we might obviously improve that going forward. And I've taken part in some live events myself with staff to hear that absolutely first hand. Also training. greater and faster deployment of digital technology, MS Teams and video conferencing, and this is a fast changing part of the market that will only improve, and we'll be able to do more of that. Mixed modes and modular training to improve ease of access to all the various sorts of training we have as an organisation. Improvement to some of our on-site facilities, digital space occupancy software, increasing our space for clinical skills, and improvements to our rest and breakout areas indoors and outdoors when our climate allows. And then lastly, workforce supply, increasing training in our apprenticeships, making greater use of our local medical school, which is a brand new one. It's in its third year, so we'll start to see the trainees coming out into placements fairly soon. We're a key contributor to the Step Into Health programme and also Get Into Nursing in partnership with our local universities. And obviously we're reviewing our recruitment practices to ensure that they have got embedded in them our values as an organisation. Now that is a very quick canter through some of the things that we've been doing to help staff recover. But Graham, as you said yourself in the introduction, this is not a quick fix. Neither the recovery of waiting lists and all that activity, but also for our staff as well. And many of you will know, you'll have seen it yourself, we've got a lot of staff that are tired, have been dealing with some quite significant challenges for 12 to 15 months. So it's a fine balance here between getting the activity bandwagon on the road again, but making sure our staff are appropriately supported to deliver it. They are critical to this. I'll pause there, Graham, if that's okay.
Thank you very much. So a couple of questions before we move on to the next speaker. First of all, I know trusts had to submit final recovery plans on the 3rd of June. What are the sort of immediate quick wins in your plan to address some of those issues?
Yes, let me just give you 3 or 4 quick responses to that. I mean, we've made, like a lot of organisations, have made some significant changes on outpatients in particular and transforming the way that's delivered as an organisation. Roughly speaking, about 40% now of all our appointments are now via either telephone and some form of virtual means. I think we can go further on that in the meantime. There's no doubt about that. We can go further with that. We've also got some pilots running with patient-initiated follow-ups in 3 particular areas to see what success or how much success we have with that. And of course, there's also a big push on advice and guidance as well. We'll also have a look at our capacity and demand as an organisation. We do that regularly anyway as part of the planning process, but that needs to be refreshed given that so many things have changed as an organisation now, not least of which, of course, are the IPC restrictions we're all working with. So we're going to take a little bit of time to reflect on have we got the right capacity and demand. And I think you'll see more sharing transparently of data from amongst the FTs within the North East community. So if there's organisations that need help in a particular area, then hopefully we can come up with a solution amongst ourselves to solve that, or at least to lead on to recovery in due course. So there's a few things, Graham, that I'd say that we're going to be looking at, certainly in the short term.
So just picking up, we've got a question from David Hare, and he's raised the issue around IPC guidance, but the second part to that, which perhaps you could answer, is given the staff coming back you've mentioned and supply and demand, how close are you to getting back to pre-pandemic levels of productivity?
Well, of course, productivity and activity are 2 different things. Just let me make that statement to start with. But I would say, as of today, if I just look at how open we are, in inverted commas, to where we were in 1920, I would say we're running at about 85–86% of where we were on inpatients and day cases compared to 1920. And if I look at outpatient activity, we're probably running somewhere around 91–92%. But in outpatients, I would make a distinction between new and follow-up. Follow-up is fairly close to 100, but new is probably running about just over 80%. So we've got some internal issues to disentangle there as well. So don't get me wrong, opening up isn't easy, but it's the easier bit of this, in my view. The backlog and the unknown is the bit that's the more difficult and challenging ask.
Sure. Okay, that's fantastic. Thank you, Ken. We'll no doubt come back to some of those issues, I think, in the panel discovery at the end, but I will rapidly move on to Jonathan Canty, who's going to give the very important patient view on this. So Jonathan's a policy officer for Versus Arthritis, and he's going to talk to us about how to support people with arthritis waiting well for surgery. So over to you, Jonathan. Thank you.
Thank you, Graham, and thank you to Connect Health for the opportunity to speak at this session this afternoon. What I'm going to be talking about is a report that we published a couple of weeks ago, calling for different measures of support to people with arthritis who are waiting for joint replacement surgery. So we just go on to the next slide. So this is what the report looks like, and just to explain, actually, the report itself is designed primarily for MSK leads at integrated care systems, primary care networks, and other services and providers of orthopaedic surgery. And I think just reflecting on some of the challenges that Ken was outlining before, we recognise that local health services face a whole range of different challenges when it comes to recovering services, included in arthritis, MSK, and orthopaedics. And we really do hope that the report we've published will help to equip local health services to help patients to work well. So to wait well for surgery in the coming months. So if we just go on to the next slide. So towards the end of last year, we ran a survey to try and understand more about the experience of people waiting for joint replacement surgery across the UK. The figures you can see on the screen here are specifically for England, but with the survey taking place during the November lockdown period, I think it gave a very strong insight into the impact of 6 months of disruption from the pandemic, as Ken was referring to earlier, the impact of postponements and cancellation of surgery. So at this stage, we could see that not only were people with arthritis experiencing lengthening waiting times, but the results also showed a significant impact on their quality of life, which we can see on the next slide. So as you can see on this slide, people with arthritis were reporting worsening levels of mobility and independence, and declining physical and mental health. And I think what this survey kind of highlighted to us, together with the other lengthening waiting lists, was the need to better support patients on waiting lists, and this survey gave us a kind of really strong sense of what those priorities should be. And if you just go on to the next slide. These were the themes that we developed from our survey, and also about half a dozen more in depth interviews with people with arthritis waiting for surgery. And so I won't go into the full detail behind each ask, but I think we think that this represents a really comprehensive range of support that people who are waiting for surgery over a longer periods may need. So the main priority that was reflected to us, particularly in our face-to-face interviews, was around the need for clear communication. And I think this goes back to a point that Graham was making at the start of the session about setting realistic expectations for when patients can expect to receive surgery. Just having that interaction with healthcare professionals really does make a big difference, and it also provides an opportunity to identify support that patients may need in the meantime. The second area is around support for people with arthritis to manage the pain whilst waiting for surgery. And in this section, we talk about some of the measures that can help to identify some of those needs, particularly through the use of shared decision making and care and support planning. We also encourage local areas to develop a list of resources that can perhaps help patients to manage the pain and other symptoms, and recommend things like commissioning peer-led support services that organisations like Arthritis can provide. The third element is to do with physical activity. We know that the individuals who are going to be receiving joint replacement surgery, that they need to be in a good physical condition to be able to withstand that treatment, and particularly if they're waiting out for a long period of time, that is even more important. So in that particular section, we signpost to a number of resources and programs that local health systems may find valuable. So that includes programs like Let's Move with Leon, which is a 3-exercise program run by Arthritis, as well as other programs that are run externally, such as We Are Undefeatable, a campaign promoting physical activity for people with long-term health conditions and escape pain. What our survey did show was a really strong link between the impact of waiting for treatments on mental health, and so that is something that we emphasise very strongly within our report. I think again we recognise the resource pressures that local areas are under, and so again one thing that can make a difference is just being able to map the local resources to programs that are available. The final 2 points are making sure that a local area is signpost to financial support and advice, particularly for people facing issues with their employment as they're waiting for treatment and facing increasing levels of pain. And the recovery plan should address these specific needs of people with arthritis. If we just go on to the last slide. So just a few pointers about how you can help here. I think firstly, there is more detail in the report, which where there's a web link on the slide here. And I think just being able to share the report with your colleagues and networks will be really helpful. I think again, really appreciate any feedback on how we can work with local health services to promote and implement these recommendations, and I just provide an encouragement for anyone on the call here today to engage with us to discuss how we can work in closer partnership to support people with arthritis. Thank you.
Thank you very much, Jonathan. We're running slightly behind time, so I just wanted to ask you a quick question, and if you could give a short answer, that would be helpful, but I think it's an important one. You mentioned ICS there on your second point. How are you finding interaction with ICSs? I know they're new organisations. Are Versus Arthritis making connections around the country?
Yeah, we're certainly starting to make those connections. We do have existing contact through the commissioning services arrangements that we've had with CCGs. I think the challenge is just trying to find that lead that is specifically leading policy and services around arthritis and MSK conditions, and I think that's where we are still gathering intelligence and information.
Yeah, absolutely. And I think we might come back to ICSs later, because the change in the system at this time is an added challenge, of course. So we'll store that for later anyway. So thank you for that, Jonathan. So I'll move swiftly on to our next speaker. So very welcoming to Emma Challens, who's the Executive Director of Culture and Improvement at Sherwood Forest Hospitals Foundation Trust. She's also founder and chair of Proud to Be Ops, and she's going to talk about addressing the backlog and restoring services. And just to make you aware that Emma's not using slides, so in case you think you're missing out. So over to you, Emma. Thank you.
Thank you very much for that, Graham. Hi Hi everyone. So yes, no slides, just a screen and my name and title. So yeah, I'm Emma Challens, as it said, Director of Culture and Improvement at Sherwood, and also the founder and chair of Proud to be Ops, which is a national network of almost 600 senior operational managers and leaders across health and care from one end of the country to the other, who basically come together to connect, learn, share, and often share the ridiculousness. So I'm just going to take the next few minutes just to share with you some insights, some learning, and also what is focus of conversations and discussions at the moment, both within Sherwood Forest hospitals and also across one end of the country to the other from our operational leaders in provider health and care organisations. So some of the things that have recently come to the forefront are, who would you now choose to be in your team to face COVID? So who do you think you'd have chosen before, and who do you think you would choose now to be in your team to respond to COVID? That's a question that's been posed to many across operational management and response to COVID. There's also been quite a lot of discussion around resilience. And what does resilience mean for me, for my team, and for our patients? And are we really clear about the terminology of resilience and its importance in terms of how we recover and restore services? There's also then the element of restoration, but with a very clear line of sight of what the future might look like. And some of my colleagues have touched on this a little bit in terms of thinking about collaborative working and what the future asks are around system shaping, planning and delivery. So although we're looking at frantically restoring our own services, how do we restore with a very clear line of sight to what that future will and could look like? So those are some of the hot topics at the moment in terms of restoring and recovering services. There's also very much being socialised from a personal leadership perspective in terms of your own values and morals, in terms of asking colleagues to keep going above and beyond. You know, the title of this session today is says, you know, now the hard work begins. Many colleagues will probably say, well, what have we been doing then for the past 12, 15 months? Is that not hard work? Has that not been challenging? Has that not been difficult? Therefore, what does the ask of us mean going forward about going above and beyond? So there's very much around their own personal values and having to recover services and get activity levels back up to a threshold which is similar to the previous year of before COVID, but doing that in a safe, supported and transparent way. So some of the conversations that are happening, particularly in Sherwood, is doing that in an open and honest way, and to be realistic in terms of what we can achieve and what we can't. And actually, as a senior executive team, to stand by that and listen to our colleagues and our clinical leaders. And we've had quite a number, almost daily, hourly sessions, executive team and our clinical leaders together in a room to have open, honest conversations and put forward plans that are realistic. But some of this also comes back to the restoration piece and the bit for the future. I take the accelerator programme as a really good example, and it's some of the conversations that are being discussed and socialised at the moment in terms of operational leaders and improvement leaders as well. So when we're looking at the accelerator programme, are we simply looking at targets and metrics, or are we looking at actually how have we used improvement and cultural development as an approach to deliver against those aspirational targets, and therefore how are we performance managing against that? So are we looking at a sustainable recovery and restoration, or are we simply trying to get activity levels back up with the risk of burnout, fatigue, to then go backwards in what could be then a challenging winter, which we've all probably heard socialised publicly recently as well, whether it's a flu likelihood increase or just what we're all experiencing, as in we are in Sherwood, just the sheer increase in demand coming through our front door. Interestingly, we do quite well performance-wise in Sherwood. At RED latest period is about 92% against the 4-hour target, which places us in the top group nationally, but equally we recognise the challenges that are ahead. So some of the things that we've particularly focused on, and some of my colleagues mentioned it earlier, is around supporting colleagues to deliver and do a good job to the best that they can do. And it's really much around well-being and welfare, targeting sessions, so we're consistently listening and adapting our approach. An example is last week we designed a specific session around coping with bereavement for colleagues, because it was at the forefront of some of their challenges of being able to turn up to work and be yourself and actually do the best that you can do. A lot of work around working with voluntary services as well. Our voluntary services have been amazing across our region and in our system, and I think it's about how we amplify that going forward. But the other real key thing here to restoring and recovery is again coming back to the system, delivery planning, and also the partnership approach. And you know, what does that mean in terms of provider collaboratives, and what's our role in that? Are we really thinking not just inward but also outward? Because it's a really key part of how we do restore in a sustainable, safe, consistent way. And some of the things that our Proud to Be Ops group are heavily involved in, and we have been able to raise a profile, is such things as the Prime Minister's Intelligent Unit, where we're discussing elected care. So before the plans, the processes go out, ops, boots on the ground people are part of those conversations. And I think that's really super important to how we do restore and recover in terms of supporting our communities and those that are waiting longest. And the last thing I will mention is don't lose sight of personal development. People need to feel educated, trained and developed to be able to keep facing what we are being asked to respond to COVID and post-COVID. So don't lose sight of people still need personal development in order for them to be a great leader and a great manager and do the best that we can for our patients. So who would you choose in your team now, and who would you have chosen before COVID? It's a question that many of you might want to ask yourselves, and would you have chosen differently? And I'll stop there in terms of time. Thank you.
Thank you, Emma. We've got a question which I guess comes immediately to your last point, and I guess you could speak at length on this, but who would you choose in your team, or what different, you know, who would you like to have had in at the start who wasn't?
Wonderful. I would certainly have key specialist welfare and wellbeing lead at the centre of all conversations which are around responding, planning and delivery. I would certainly have, coupled with that, psychological support. I would have credible, trusted clinical leaders in that forum, so getting the right people. Voluntary services, without a shadow of a doubt, I would have key and involved in that, and also primary care clinical leads involved in that team. And the chief exec involved in every discussion, every meeting, to gain a true understanding. And the final one I would choose in there is having that nursing infection control. But would we have all before gone straight for welfare and well-being? Would we have all before gone for informatics and business intelligence? Maybe, maybe not. Would we have all before gone for voluntary? Some really key things to think about, and there might only be 10-15% that might be different, but that 10-15% could make a hell of a difference. So that would be some of my insights into that. And of course myself. I like to be in the centre of it of all time, both with different hats on and my role in terms of supporting people and the culture.
Thank you. Just a comment from me. It's interesting. I think people have considered this throughout COVID, how nature has a way of resetting things. and it's very interesting to hear your points there around welfare support for patients and staff from a holistic point of view. And I think that is one thing, certainly coming with my primary care background, that I would put forward as well. And indeed, it leads on very well to our next speakers. So thank you, Emma, for that. That was fantastic input, and we'll come back, no doubt, to you later. So next speaker, I'm delighted to introduce Mo Taylor, who I've known for some time, and initially as a senior leader within Northumberland Healthcare Trust. She moved across to some other side. You can perhaps describe what it is, Mo, in terms of the local authority in Northumberland Council, and we know that integration with the community local authority is going to be so important. So Mo's going to talk about integration from a local authority point of view and steps to recovery. So over to you, Mo. Thank you.
Thanks very much, Graham. Good afternoon, everybody. I'm Mo Taylor. I'm Director of Business Development and Communities for the local authority, and just want to give you a bit of a local authority viewpoint on the pandemic, with the flavour of how we've handled that and how we want to move ahead in Northumberland. So we just have the first slide, please. So a time like no other. I've had 30 odd years in the NHS and the last 2 or 3 years with the local authority, and my goodness, this has been, you know, a challenge for everybody. And I think it definitely for me brought the role at the very beginning. Rabbits and headlights, I think, would be a good term at the very start of it. I think we're in a much stronger position now. There was a requirement for us all to rapidly develop systems and services in a very different way. You know, we had staff who couldn't come into work, we couldn't perform in the way that we had before. We had to be innovative about what we were providing. And just in terms of Northumberland, you know, we are a very rural, coastal, the most northerly county in England. 320,000 residents. We have a staff team of about 10,000, including our school staff. So not a small enterprise, a very meaty enterprise. So being able to manage all of that and respond in the way that we needed to, what was incredible. And again, as others colleagues have mentioned, the balance of the impact on the residents and patients, but also the workforce, because, you know, if they're not there to respond and we're not supporting them, then we were going to get ourselves into some hot water. You may or may not know that the local authorities take a significant role in emergency planning and emergency responses. So when the health system at the very beginning of the pandemic needed to limit attendance and protect their systems, social care, community services, home care had to continue with that community provision, and were under immense pressure and continue to be. And we needed to support them to make sure that they could keep people out of the hospital system that was protecting those that desperately needed that medical support. Food, issuing emergency food packages, getting medications out to residents, keeping primary care supported, huge amount of welfare support and mental health support for residents. We did a huge amount on communication and support for them. Literally overnight, we had 25,000 of our residents who were shielding. And a big proportion of those, as Ken said, impacted on the workforce as well. So these were big numbers. These were kind of really important factors to the system. Shielding, by definition, means that those individuals have had a health vulnerability. So on top of everything else, that we still needed to try and find a network and a way to support them. We also, you know, pushing out huge amounts of support in terms of finances and grants to keep care providers operating, the care homes, the home care providers, all the school support and all the business support. So we're talking hundreds of millions in grants having to be pumped out into the system, as every other local authority was having to do at the same time. Just pop on the next page, the next slide, please. So in Northumberland, we're in a good place. We had good foundations. We have an integrated model with our local trust and with our mental health trust. So we had some good foundations to work on. But I think what this has brought about is a much stronger understanding of the vulnerabilities in the population and the health and wellbeing needs. You know, that business intelligence, that pulling together with primary care to understand where are these vulnerable people, how are they going to be supported, How are you going to protect the system, the primary care system, to then subsequently support the acute system? And what we did was we developed some significant new relationships with our community. There is an inordinate amount of support in voluntary sector and communities that we hadn't harnessed on this scale before. So I'm talking 300 plus community groups across the county who were there. They had some energy, they had some innovation, and we captured them and pulled them together to mobilise that kind of support. And we started to understand what social prescribing and support planning actually meant in practice. So we took the plans and a bit of the rhetoric and turned that into a real model of delivery. Next slide, please. So through pandemic, was born our model, which is Northumberland Communities Together. And the purpose of that was we needed to look to restore and support independence in that elderly population, but also those very deprived areas. As we were seeing the consequences of shielding, we're seeing that now, that although shielding was lifted in the summer, there is still reluctance for people to re-engage with the system of support. There is a lot of reduced activity. There is reduced confidence in accessing care services as well. We know that a lot of the elderly population are reluctant and they're not sure about their entry points so much, and that's having an impact. So primarily we wanted to try and continue to reduce demand on primary care and the acute sector, but also the statutory services who were under huge pressure in social care to make sure that people got into the system at the right time for the right reason. And in Northumberland, similar to other health systems, we have had a very long held ambition, but we've never prioritised it in the way that we're doing now about managing the demand outside of the health system where that's the right place to do it. We are much more focused on community support, much more focused on supporting at an individual level, working with groups to actually manage those wider determinants and getting that well-being factor much more in focus for the system in Northumberland. Next slide. Oh, no more slides. Anyway, that was quite a rattle through, but significantly, I think local authorities maybe haven't had the news around maybe health systems that have been in the focus, and quite rightly health systems need to be in the focus. You are waiting with a backlog. What I'm suggesting is that local authorities can support that, but work in a different way with local communities and get that resilience to build that resilience to allow individuals to take responsibility for some of their own health and well-being, and to try and stop this flow, because it will be like a tsunami. We've seen the figures there from acute care colleagues. There is a lot of unwell people in the system, and we need to try and slow that down by whatever means that we can. So if you want to hashtag Northumberland Communities Together, you'll see a lot of activity around what we're doing in Northumberland, and I'm happy to take any specific questions.
Thank you very much, Mo. Could I just in terms of the council's role in system recovery, I mean, you've sort of outlined the willingness to be involved. Is there capacity within the local authority? We obviously heard a lot about healthcare, the pathway, and we're going to hear from Chris in a moment about primary care, through to the challenges in secondary care. What is the capacity of a local authority and the council to assist health and obviously specifically patients to get through this difficult time?
I think there's two kind of key opportunities. One is within our integrated system about, how we support those pathways with the clinical support and the social care support. The other side is the community side, which is the thing that we need to put a bit more of a spotlight on. I think there's more we can do with the voluntary sector and community groups to support their own well-being on the back of, them understanding what their needs are. Some of the health needs and some of the the symptoms that come through are from wider determinants. We've engaged with people in social care activities because they've been worried about losing their jobs. they've been worried about, you know, managing their own health. They've ended up in primary care. They would have got into primary care pre-pandemic for all of those issues. Now we are trying to deal with those, quite rightly, before they present in primary care, because we can find the solutions to support them. So I think it's about being a bit more aware of what a local authority can do when it puts its mind to it, and being a bit more aware about where the local authority sits in the system. It isn't about, you know, well, it is about emptying bins and looking after parks and providing adult social care, but it's much more than that. It is about, you know, harnessing what's available in the communities and putting that to really good, productive use.
Okay, thank you. So yeah, so what we're hearing is you may be ahead of primary care in terms of the patient pathway, or we're not to call them patients, members of the public. And so thank you for that. And that feeds nicely into our last speaker, who's Chris Lyon, who comes to us from primary care. He's head of operations in Cross Counties and North Blaeberry Primary Care Network, PCN, and director of East Leicestershire and Rutland GP Federation. And he's going to give us the primary care perspective on managing demand and improving outcomes. So over to you, Chris. Thank you.
Thank you very much, Graham. Really, I'm going to put things into perspective before I launch into my slides. I'm going to talk a lot about LLR, which is Leicester, Leicestershire and Rutland, which is the local health economy, which is in the process of converting to an integrated care system. So with everything else that's going on, we're also in the process of major reorganisation. We're looking at the system, the place and the neighbourhood working, and we encompass one large acute trust, one large community trust, 25 PCNs, and from my perspective, East Leicestershire and Rutland Federation, which covers 7 PCNs in the East Leicestershire and Rutland area. Leicestershire is a bit of a donut, a ring donut at that. And actually, whilst we talk about UHL and LPT, there are a lot of people that live on the periphery. Market Harborough is a good example, which is within one of my PCNs. A lot of people go to Kettering, which is actually in Northamptonshire, for their healthcare needs, and that adds an extra layer of complexity to what we do. Can I have the next slide, please? Thank you. So how has the pandemic affected primary care? Well, a lot has been said about this already, and there are a lot of similarities between the primary care experience and secondary care and local authorities and everything. And there are some bad and some good things to have come out of this. So, for example, and a lot of people have commented on this locally, premises pretty much closed instantly. Some even locked their doors. There are some concerns about resilience. With small and large practices, you would expect the resilience for worries around small practices, but some of the larger ones suffered as well. There's been an impact on staffing, both through shielding, isolation, people actually contracting COVID-19. We've had to rapidly move to virtual appointments, and that proved to be somewhat difficult for some of the practices. And a real increase in mental health contacts. Some GPs have reported 70% of their daily workload is low-level mental health, ranging from low-level mental health to people who are genuinely suicidal on the other end of the phone. ED has been empty, so patients are nervous about seeking help. Having said that, I think UHL had its largest ever attendance last week of nearly 1,000 people through the door in a day. But over the first 3 months or so, ED was virtually deserted. And people found different ways of seeking help, or actually they didn't seek help at all, which is more worrying. Primary care has become the contact point of last resort, and we've heard a lot about particularly secondary care who have quite rightly put elective procedures on hold and have slowed down all of their activity. What the man in the Market Harborough High Street has tended to do is when he's got to the end of his tether, he rings the GP and asks what's going on, and that, for a number of reasons, has contributed to the increase in telephone workload. added to the fact we've shifted over onto a telephone triage system. And as I said, I mean, that's suspended secondary care services. I mean, that has added to the workload. There are some good things though. The shift towards the technological solutions that we've implemented has been really rapid and in most cases really very effective. Changes in working practices which we've had to put in place. There's been some remote working, there's been home working. People like myself who have been shielding have managed to set themselves up in their spare bedroom and get on with life. Vaccination programme, which the PCNs have been an enormous part of from between Christmas and New Year in my case, have to a greater extent allowed the updating of patient records. The number of patients we've had to contact and update records as we've gone along has been an enormous benefit to actually our GPIT systems. And the PCNs have matured rapidly. They've had to mature rapidly. They were about less than 12 months old when the pandemic hit, and actually they've had to move rapidly into dealing with that, and then rapidly again into dealing with the vaccination programme. Can I have the next slide, please? So primary care recovery, and I'm talking now about primary care in its purest sense. Practices and PCNs have now got to work out what normal is. That could be a return to what normal was, but I think everybody recognises this is a golden opportunity for primary care to change what normal is. And I think that's a mix of face-to-face and virtual appointments. And then we need to work out how we make that normal a reality. And we don't underestimate the challenges of that, particularly with our patient participation groups and their need to sit in our waiting rooms with their drippy noses waiting for the doctors to see them. We need to play an active part in the system recovery, and we need to lead, and we need not to follow. And my two PCNs have tried to do that, and I'll come to that in a minute. But we need to use our additional roles. Mo talked about social prescribers. In both PCNs, we have social prescribers and health and wellbeing coaches, plus the physios and the clinical pharmacists. But they played an enormous part in directing people into other services and directing them to help, particularly with financial issues. And again, the GP practice becomes the telephone call of last resort. How do they seek help? But also we need to look at community pharmacy service 111 and our additional hours services to increase our capacity. Last slide, please. So how do we play our part in the systems recovery? We need, I think, as primary care to open up as quickly and as safely as we can. And to a greater extent, a lot of the practices that I work with are already doing that. We need to work within the system to promote recovery. We're trying to build links with UHL, University Hospitals of Leicester, and with our community trust, LPT. We're working on a federation level to bring them onto our board. To allow wider conversations and to develop strategies between us. We need to work out what we can safely move into primary care to help with the system recovery. And we quantify that at 4 levels. So system, I mean, that's across the whole LLR. Place, which is East Leicestershire and Rutland Federation level, our PCN, and also at practice level. Practices can help. On their own. They don't need to work as a collaborative always. And we need to work on pathways that allow primary care to keep patients away from secondary care. A couple of the examples of that are we are about to start a PCN delivered spirometry diagnostic service so that we can keep people away from UHL, but also take some appropriately off their backlog. So we can cut the backlog off at the bottom, but also take some off the top. We're looking at how we can work with both of our trusts to keep people in primary care as long as possible, and that includes a COPD service for complex patients, and also an initiative in Market Harborough with our elderly medicine consultant colleagues from UHL to work on frail, fragile people in the community to stop them escalating into primary care. It's secondary care, beg your pardon. They're already in primary care, hopefully. And I just want to pick up very, very briefly what for Maureen's themes. Some of the relationships we're building are with our local authorities. North Blaby PCN and Blaby District Council have a very close working relationship, and Cross Counties and Harborough District Council are developing in the same way. And for the future, I think those local collaboratives with our community and voluntary sectors as well are key to getting ourselves out of this and getting ourselves back on an even keel. Thank you very much.
Thank you very much for that, Chris. So just a quick question to you before I open to the panel. So in terms of primary care, is the recovery of the system as a whole, it all starts with primary care. I know there's significant challenges to the staff within primary care. Have you got a sense of where that's going? We've heard from other sectors as well, and it's something we'll come to. What's happening with morale, recruitment, retention in primary care?
It's probably very similar to other areas. I mean, morale is patchy across member practices. Some are more resilient than others. Some are struggling with staff leaving. Some are struggling with recruitment. Others seem to be doing okay. It's not a consistent picture across either of my two PCNs or across LLR as a whole. The system, the issues are magnified for the PCNs that cover Leicester City. I think they're struggling more than the county are, but the county have different issues that we're struggling with separate to that. I just think we need to concentrate on both on our own system recovery, but also whilst doing that, we need to ensure that we play an active part in the recovery of the system as a whole.
Okay, thank you very much, Chris. So I'm going to open up to the panel now. Please keep asking questions, and I will put them to the panel. I'm going to start with Ken and then go to Emma. And the question is, having heard some of the other speakers, that there's a clear desire for everyone to work together. We all know that makes sense. How can you in the trusts, with everything that's going on and all the complexity you have, actually best use the help of the community, of the council, of primary care? Is there anything that can be done immediately, or really are we looking for 6 to 12 months time to stop the flow, if you like? What's the approach to that? Have you just got to get on with it, or is there something that the system can provide now to help in secondary care? So to Ken first, and then we'll come to Emma.
Well, I mean, I suppose in answer to that, I would say that we're not completely separate organisations at the moment. A lot of our services are working very well on the ground and have done for years and years and years. I think sometimes it's the organisations that get in the way actually of progress, rather than some of our staff actually delivering some of our services now. So we've always worked well together. I don't want to see this, though, I have to say, as a quick fix. And I say that because I've had thousands of these quick fixes in my time in the NHS, the current fad and fashion. I think this is about embedding local partnerships and working for the long term, not for the short term. And I think that comes back to some of your key themes at the start. It's less about an individual organisation's success now, and more about collectively what are we doing for our patients and our residents. And all the speakers you've had on the session today will all play their part in that. So for me, this is the continuation of a conversation, a transparent conversation about what each of us can do to support each other, because we all need to listen to the problems that each of us have got to find some solutions collectively together. So I hope it's not a quick fix, Graham. I hope this is the start of a longer term, the embedding of health and well-being, to put it in summary form, of our residents and our patients. And I think I would like and make a plea that actually some of our policymakers, nationally in particular, also start to take a little bit of a longer term view. And I am very hopeful the ICSs in particular will now give us a little bit of a platform, both at place level and at system level, to do exactly that.
Same question to Emma. Thank you, Ken.
Thank you. It's a really good question, and I kind of do agree with Ken on many aspects there, and I think the key thing is that, you know, some of the terminology being used is, you know, COVID was a blessing in disguise because of the rapid change, partnership working and improvements had made. Many of us probably might think that COVID wasn't a blessing in disguise for many reasons, but this is the feeling of what it's released. And I think for me, there's really something strong in that about power, and our response to COVID almost moved power out of the equation to some degree and started to create much more shared power than let's say single organisation power or single leader power, because I think Ken makes a good point that actually this is about leaders having a very different attitude, mentality and style to working collaboratively that is more sustainable in the future. So that shift in power, I think, has to be maintained and pushed and stretched to really test that. And I think that has to be supported at a regional level as well, in terms of allowing that to happen in a safe, supported way. So I think the power and the shared power is certainly something that I think we need to really pay attention to going forward.
Okay, thank you. Just a question to Paul. We've talked a little bit about the public and expectation. What's your feeling about where that's being pitched at the moment? And I guess we've mentioned politicians, perhaps press coverage. Do you think the public's exactly where it needs to be in terms of expectation, or is expectation too high coming out of COVID? Paul, what's sorry, Jonathan, not Paul. So that question to Jonathan.
Sorry, can you just repeat that question again?
Yeah, my apologies because I got the name wrong. Yeah, so where do you feel the public is in terms of expectation coming out of COVID? Is there too much expectation? Is it being appropriately set by the politicians, by health leaders, and by the press?
I think certainly the feedback that we've gathered throughout the pandemic period, at least among people with arthritis, is that people were incredibly pragmatic about I suppose where the NHS had to prioritise its resources. I think that was clear certainly in the opening months after the first lockdown. I think the challenge now, though, is that because people had obviously been waiting for longer periods of time, as I was talking about before, sort of living in various levels of pain and dealing with other symptoms, I think there is a greater desire now for clearer communication from local health services. As I say, I think, you know, there is a realism about the length of operations, and it may take a long time to be treated, but I think just to have some kind of communication and to be signposted to different levels of support that are out there, both within the communities, from voluntary organisations or from local authorities, for example, would make a big difference.
Okay, thank you very much, Jonathan. Apologies for getting your name wrong. Just for the final minutes, I'm going to go to each speaker in the order they spoke and just ask for one thought or action that you think is really important to assist in recovery. I know that's really difficult, but what do you think the key thing is in 2 sentences? So we'll do them in order. Ken, if you can go first.
Well, let me turn it around and let me tell you, or let you know, a question I'm asking every single member of our team at the moment. And the question is, why is it taking a pandemic for us to fundamentally change the way we work?
Okay, that's a key question, isn't it? And to take forward. So thank you for that. So next in order, we'll go to Emma.
Thank you. How do we, I suppose, think changing the way that we performance manage systems in relation to the ask of delivery.
Okay, thank you. Jonathan.
So we recognise that it's going to be a long road to tackling the backlog for the surgery. So please work with patient groups like us to support patients to wait well over the coming months and years.
Thank you very much. Mo.
Just come off mute there. I think what we should do is share what we now know. We need to share that. I think there are some blind spots for different organisations, and we should share what we know now about residents' behaviours, patients' behaviours, workforce issues. I think we just need to have a huge collective understanding of those pressures.
Okay, thank you, Mo. And finally, Chris.
I think primary care needs to work through primary care networks and federations and other similar bodies to play an active role in the health economy as a whole, and the advent of ICSs will help that. But primary care needs to stop seeing itself as just a GP practice. It's much more than that.
Thank you, Chris. Okay, thank you to all our speakers. It's a challenging topic. I don't think anyone, as I said at the start, has got the answers to it all, and it's been discussed in various fora around the country and will continue to be. But I think what we've heard today is it is about working together for patients, not forgetting welfare of our colleagues within all the sectors that we've talked about, because that's incredibly important as well. And thank you for the comments, particularly from Emma, around their personal development is an interesting one that we haven't thought about. So thank you all. Thanks to everyone who's joined to listen in and contribute with questions. Please just don't forget to fill in the feedback survey. It just takes 2 minutes of your time, and it does help us develop future topics. And just to make you aware, our next webinar is on the 14th of July, which is on cultural communities and health inequalities. And after the summer, we're also going to tackle COVID rehab, which is obviously relevant to today's webinar. So hopefully you can join us with that. All the information is on the website, as will be the recording of this webinar if you want to recommend it to any of your colleagues to have a listen to. So on that note, I thank everyone, Ali and all the crew who've organised, all the speakers and all of you for joining. So have a good rest of your day, and fingers crossed 12 months from now we'll be in a much better place. Thank you.
Thank you, everyone. Take care.
Thank you. Bye.